So looking into what has been done, we moved the tissues to the buccal and therefore accepted that we would have a recession to the apical, but this did not increase the thickness of the tissue. So thickness of the tissue in this case would have been certainly one of the fundamental criteria to stabilize this. And if you even look closer into this case, into the initial radiograph after abutments had been placed, you can see that we have two completely different abutment profiles. So we have a very convex shape as the technician tried to even support more and apply more pressure onto the surrounding tissues, whereas just by accident back then, as we had no information on what could happen, the concave shaped canine maintained stable over many years. So when it comes today to decision making and to designing an abutment without manipulating the surrounding tissues, there are some criteria that should be followed. One, and that gives a very good information for the dental technician on how to design the abutment, is the morphology and the contour of the margin should be exactly as the contralateral tooth. That means that he needs to perform a perfect wax-up, and from this wax-up he will immediately know what contour and shape the abutment has at the cervical margin. And the second parameter that needs to be considered is to give the tissues, the peri-implant tissues, as much room as possible, and therefore create a concave contour of these abutments, however always respecting the material properties so that the abutments do not fracture upon clinical loading. Finally, I would like to end this session with some clinical findings, considerations, especially when it comes to adjacent abutments. Again, a case, conventional two-stage approach, the implants had been in place. We used a resin-bonded temporary restoration, as this gives adequate time for healing. We can condition the tissues if we want to, but most importantly, the patient is not impaired in his daily routine, speech, chewing, everything is working perfectly. Therefore, these provisionals are really a good alternative if we use a two-stage approach. And then we finalized the case, as you can see here, with two zirconia abutments and two ceramic crowns, which looked quite interesting and nice initially for considering the initial clinical situation. But what the patient presented with at the 2-year recall was that we had a significant different morphology of the cervical margins of these crowns that were present only if we lifted the upper lip, because as you can see here on the right image, the patient had a very low lip line. But what was the reason for this was that the technician had two different contours of these abutments. And what we see now in many cases, whenever we have used the zirconia abutments after 5 to 7 years, is that the tissues stabilize, and in many cases they stabilize at the interface between, at the cement line, at the interface between the crown and the abutment. And therefore, just as a recommendation without any clinical or scientific long-term evidence for this, I can only recommend that whenever you have two adjacent implant abutments in the anterior maxilla, for example, that you really consider, and your dental technician considers, that these abutments are contoured alike, so that if tissues mature, if tissues stabilize on the zirconia surface after time,